and we have this month's journal club. Usually, we choose those articles those have some impact on our current clinical practice. And Dr. Goda and Joannes have come up with four interesting articles, and our fellows would read. We have two experts. We all know them. Ashish Ranade is from Pune, uh, a very good friend of mine, and Mandar Agashe from Mumbai. So let us start the first paper. I'll invite Dr. Meet Jain. Meet, please start your paper.
Yes, sir. Thank you, sir. So I'll be presenting a paper. This was titled a randomized control trial comparing immobilization in above knee POPs compared to that with control ankle motion boots in undisplaced pediatric spiral tibia fractures. So this was published in the Emergency Medical Journal in 2021, and the study has been conducted in Perth Children's Hospital, Australia. So to give a background of the study, the tortoise fracture, this was described in 1964 by Dunbar et al. And it is an undisplaced mid-shaft tibia spiral fracture. And the recommended line of management is an above knee cast for 6 to 8 weeks. So the importance of early weight bearing is what has been stressed by the authors. And the importance is that it promotes callus formation along with a faster union time, prevents muscle wasting, and prevents disruption of weight distribution. So, controlled ankle motion boots, these are routinely used for ankle injuries. However, the authors have said that since toddler fractures are stable fractures, we can use it for these as well. So, the hypothesis was that children in cam boots have lesser disruption in the routine activities of daily living compared to above knee POPs. Aim was to compare the two methods of immobilization with a proven or a presumed toddler fracture. So this was a prospective RCT. The age group was 1 to 5 years. Inclusion criteria, along with the age, was a radiologically confirmed toddler fracture or a significant suspicion based on the mechanism of injury without obvious radiological findings. However, the time since injury is what has not been specified by the authors. The exclusion criteria is a concurrent fibular fracture, which would make these fractures inherently unstable, and any underlying bone disease or chronic illness. So the outcome measures which were used by the authors was the primary outcome was based on the caretaker, and it was assessment using the personal care and comfort questionnaire. The secondary outcomes were activities of daily living assessment using the positioning care and comfort question, that's a CCQ, comfort care questionnaire, and interaction care questionnaire. So these the care and comfort questionnaire are they include multiple parameters, and that, as we can see, it's personal care, positioning, comfort, and interaction. Also, the pain assessment was done. This was using a visual analog scale. This was done both by the caretaker and the doctor. And complications of fracture healing was noted, and assessment of the weight bearing status was done. So outcomes were measured at 5 different time points. The first was when at presentation. This was done by the physician and caretaker both. The second was done on exactly the next day. This was done only by the caregiver. The third was done on 7 to 10 days. This was after a check X-ray was done by the research staff, along with a change into cast. And the fourth was at the clinic at 4 weeks when the removal of the cast was planned. And fifth was just by a telephonic conversation at 1.5 to 2 months. So this is the main primary outcome measure. It's a personal care and questionnaire. So the things that were measured was, as we can see, there are these are the routine activities of daily living which a toddler who is a mobile individual but highly dependent on the caretaker, they have to undergo all of this. So the power of the study was kept at 80% with an alpha value of 0.05. The estimated standard deviation was 3.2. However, the authors have stated that there was no previous data or literature to base the sample size. So, after they recruited 50% of the patients at 6 week follow up, they did a review of their own sample size, and they achieved a sample size of 87. So it was an intention to treat analysis, and the pain and activity scales were measured at all time points, and these are reported across the multiple time points as mean and standard deviation. Healing was seen on the X-rays. Weight bearing status and complications were reported using descriptive statistics, that is, frequency and proportions. And the chi-square and Fisher's exact test, these were used for difference in categorical variables. So the results were that out of the 116 patients who had presented, 28 were excluded, and enrollment in the study was done for 88 patients. One patient had a error prior to the randomization, so was he was excluded, and so now have a total of 87 patients. So out of these, after randomization, 44 were allocated to the CAM boots, and 43 were allocated to the above knee POPs. So again, there were a few misdiagnoses which were seen at the 1 week follow-up. So these were excluded from the both the CAM boots and the above knee POP groups. And finally, the analysis was based on 41 patients with CAM boots and 40 patients with above knee POPs. So the results that they found was that radiological evidence of fracture was seen in 59 patients, that is 67%. 31 of these were in controlled ankle motion boots and 28 in POPs. However, there was no radiological evidence in 25 patients who were the so-called presumed toddler fractures. Out of these, 10 were in the CAM boots and 15 were in POPs. Uh, at 1 week follow-up, 7 out of 25 had developed radiological evidence of fracture. However, the other 18 patient data is not been disclosed by the authors. So, if we see the primary outcome results, the personal care CCQ, it was the CAM boot was the difference between the personal care was highly significant in favor of the CAM boots on the second day in the on the next that's from date 7 to date 10, that is the TTP3, and at the fourth time point. So only after removal was there no difference between the above knee POPs and the CAM boots. Next is the weight bearing status. So there was a significant difference in the weight bearing, as we can see in the CAM boots. The weight bearing was also earlier, and this was seen at the third time point, that is just during the removal of the cast. One patient had underwent a crossover from the CAM boots to the POP groups. One patient had suffered a repeat fall with CAM boots and so had to be converted to a POP due to increased pain. There was no difference seen in the pressure areas. Pressure areas were seen in both groups. However, the CAM allowed earlier identification of these pressure areas. So, in discussion, the authors have stated that toddlers fractures are unique in that they are seen in mobile children, but highly caretaker dependent. So, a caretaker focused outcome was selected. The current practice in Australia is to give an above knee POP for all toddler fractures, and multiple studies have been done which have supported CAM boots, below knee POPs, or even no immobilization for such fractures. The pain score was different at the TTP3 and TTP4 for the caretaker and the doctor. The pain score, as measured by the doctor, was found to be much less compared to the caretaker. However, when we see both the groups, that is the CAM group and the POP group, there was no difference between the two. The limitations of the study, which the authors have said, is that it was a single center study. They could not do blinding during the study. So the potential bias from the medical staff and the parents was there. Also, the authors also stated that there was an inappropriate cam boot sizing which was changed during the review visits. And conclusion, they have concluded that the study provides trial evidence that all undisplaced spiral midshaft tibia fractures can be mobilized in a CAM, which was their primary hypothesis. Some limitations that I have found was that patients who did not have any obvious radiological diagnosis, what were the outcome measures? Was it only clinical? How was the healing measured? Second, in our setting, there's a financial constraint which needs to be considered. So a cost benefit analysis would also be worthwhile for these patients. And as has already been mentioned by the authors, the bias had to be the blinding needs to be done so that the bias can be eliminated.
Right. So nicely read paper, neat. And I will invite Mandar to give his comments about this paper, and then Ashish.
So I think what the last slide is has encapsulated what I felt about this article. Is that in our setting, the financial things also need to be considered. That a toddler's fracture, we cannot have a sort of a removable kind of cam boot every time. And again, making that cam boot is also going to be an issue. So, toddler's fracture is I feel toddler's fractures are something like clavicle fractures. They heal up whatever we do, and in spite of what we do. So it all depends on the comfort of the child at that time. So if I see a child uh, who is unable to bear weight and is in significant amount of pain, I don't mind giving a cast for a few days. Typically, the child comes with a broken cast by weight bearing on it, and I allow weight bearing on that cast. So though they have, it's a very nicely done study, and they have compared these two important things. Uh, it's something which I don't think is very important in our clinical practice, to be frank. Ashish, what do
Right.
you feel?
Yeah, I agree. See, I thought the thing about these toddlers fractures is there is no defined standard of care. So any new treatment which one has to compare with the standard of care. So it varies from no immobilization to cast. So it's no brainer using a boot is easy, but as pointed out earlier, cost and all those things are a problem. So I don't think it will change anything as such, really.
The thing which I feel is if a child with toddler's fracture comes to your clinic, and there are two types. Some of them are walking with a limp, and some of them are not able to bear weight. Now, if you send them for an orthosis, it will take time to take measurement, and it's a customized thing. You cannot apply a single size to everyone. So it will take some time for even this cam boot to be formed. So, and that's again a cost thing. And at the same time, taking care of plaster sometimes is a pain for families. So my practice is if there is spiral fracture, not very painful, and child is walking a bit, then you can advise this. But in as Mandar said, that if it is very painful, swollen, then you can give a back slab and see them back. Now, of course, we are talking about this spiral diaphyseal fracture, right, Meet?
Yes, yes, sir.
So there is no question of this Posen phenomenon or anything. Yeah. So yeah, more and more we see patients are for buccal fractures of radius, and those we our orthosists are there making very quick thermoplastic splints that work, but it cannot change our practice completely. So let's move on to the next paper. Uh, who is going to Chinmay? You are taking it. Please share your screen. Yeah, go.
Are you able to see my screen, sir?
Yes.
Okay, sir. Good morning, everyone. Myself, Dr. Chinmay. I'm a pediatric orthopedic surgeon working in Amaravati. Today in Orthokids Journal Club, I am presenting a paper which was published in International Orthopedic 2022, a paper from China. The author is Yan-Hin Liu et al. The title of the paper is a closed reduction and percutaneous spinning versus open reduction and internal fixation for Jacob type 3 lateral condyle fractures in children. The type of the study, it is a retrospective study of prospective enrolled patients over the period of 3 years from 2018 to 2021. The background of the paper is that lateral condyle fractures are the notorious fractures to treat, mostly when the fracture fragment are rotated and displaced fragment. So there are n number of complications associated with this type of fracture in the form of avian and a non-avian. Introduction part of this paper, the paper talks about the historical event that take place to classify this type of fracture, starting from Jacob 1975 about the theory of cartilage bridge. The cartilage bridge, if cartilage bridge is there, there is a less chance of secondary displacement. Then come up the paper with a Foster in 1985 about displacement of 2 millimeter criteria, less than 2 millimeter and more than 2 millimeter. Then the 2008 internal oblique X-ray view gives the idea of the fracture line extend into the intra-articular portion and stated that the closed reduction has several advantages over open reductions. So aim of the study is to, main goal of the study was to evaluate the feasibility of closed reduction and percutaneous spinning in a patient with type 3 lateral condyle fracture and to assess the outcome of each injuries according to the type of treatment, closed reduction or open reduction. So in material science method, total 87 patients were included in the study, 4 were excluded and 5 were lost of follow. Out of which 36 underwent for ORIF and 42 underwent for close reduction. Out of 42, 3 were failed. So total 39 patients were enrolled in the study. The reason for 3 failed cases, out of 2 have a age less than 3 years and they are 2 cartilages to see under the CM. That was the reason given by the day. In inclusion criteria, patient with a confirmed diagnosis of type 3 lateral condyle fractures, open growth plates, treatment at institution within 24 hours, standard preoperative AP and lateral radiographs, follow-up more than 12 months, and complete clinical and radiographic data. In a surgical technique, the surgical technique for close reduction, they mentioned they pass the 2 millimeter Steinman pin or a K wire across the joint line to evacuate the hematoma so the swelling gets subsided and they can manipulate the fragment with a thumb pressure. First, they give the varus force to the elbow so the elbow joint can open and place the fragment at desired position, after which the 3 K wires are passed in a divergent manner. If the fragment is not placed in a desired position, K wire can be used to use as a joystick method. For open reduction, they use a standard lateral approach, see the reduction under the vision and place the 3 divergent K wires. Talking about the results are more of the same, but on a characteristic point that fluoroscopic time and operative room time is significantly more in the CRPP because of close reduction. We have to see multiple Siam shoots. In a discussion, the paper is mainly discussed two of the author, that is Song et al. And Lee et al. They have their paper on a successive patient. So they stated that they have 75 and 78% good outcome in the respective studies. So in a current study, they stated about 92.9% good outcome in their study. Their higher rate of the success, they given their reason that they are due to the evacuation of hematoma and swelling, they can easily manipulate the fragment to keep it in a desired position. Lateral spinning is nearly seen in all of their patients, ranging from 35 to 77% of their close reduction patient. In a conclusion, they come up with that close reduction and ORIF had a similar clinical and radiological outcomes. ORIF only considered when a satisfactory reduction cannot be achieved. Now coming to the limitation, apart from the limitation, what author is stated, some of the limitation I personally seen starting from the references. The first references is that they stated that Jacobel classification, but in a referencing the fourth number is given some another paper. Similarly, in a paragraph, they stated that most of the surgeons prefer open reduction and internal fixation for the lateral condyle fractures, but the paper they quoted are most of the close reduction paper, and they given and all this paper given that a close reduction give a better result, and open reduction chances are minimal when the surgeons are not comfortable with the close reduction in post-op X-rays. Now coming to the reduction maneuver, what the close reduction maneuver we do because we preserve the hematoma, and that hematoma will eventually help into reduction to get the fracture healing. Here they evacuating all the hematoma. The second part is the thumb and forearm position. Apart from thumb positioning and varus positioning explanation, some of the time these type 3 fractures have a tendency to migrate proximally, or they cannot be placed significantly into the joint. So apart from varus, the valgus positioning is also important of the forearm, because this valgus position radial head compress the fragment in the position, and at the same time thumb can be used as an anti buttress effect over the proximal fragment. This is was excellently explained in Prusik et al. Technique in 2018, and this technique is very much useful whenever we treating this type of fracture. Again, the inclusion criteria, they confirmed, they stated a line that with a confirmed diagnosis of Jacob type 3, but in the tables, they mention about the Milch classification, because the type 3 classification have a 3 parts, that is minimal display, more than 2 and less than 2 fragment, and Milch have a different perspectives. Again, the hardcore classification, hardcore criteria was evaluated for the functional outcome assessment. But what I feel, apart from this, there should be there should be another upper scoring system which can be used to assess the functional outcome assessment in a day-to-day activities. Implication in our practice that we are routinely doing this, and this is not much a practice-changing paper. Thank you, sir.
Okay. So, Ashish, what do you think? Nicely read paper, more so reading between the lines, and this is the way the reviewers would read it. So, that's nice reading.
Thank you.
Yeah, Ashish, your comments?
So Chinmay, excellent presentation. That's exactly what are we looking at.
Thank
So
you
I
so much.
completely agree with all your findings, and even it's a balance between uh, we don't know, by saving on the radiation time, the how good is that in terms of union? So probably I agree with you. The outcome criteria should involve reports by the patients and parents, which one they prefer, rather than surgeons assessing it based on radiological function.
Yes.
So I think yes, it has a role, but we need more studies to tell us which one is good, and particularly in terms of what.
Yeah. Um, Mandar, are you there?
Yeah, see, I agree with Ashish and Chinmay. The only thing is that again, so there have been a few papers about close reduction of these displaced fractures in of these displaced supralateral condyle fractures. Now the main issue is that I don't know, I may have missed whether they have included the song 5 types, which
No,
are the
sir.
displaced. They
Uh,
have or they have not.
No, so their criteria is Jacob classification, sir. They don't
Correct.
use the songs
They have
classification.
not. Correct. So again, getting a reduction for these see these grossly displaced rotated fractures by close reduction is something which is very unlikely with close reduction. For even if they have not analyzed strong three, the what we know about it is 3 and 4 types. They are amenable for close reduction, and I
Yes,
think that has been established quite well.
yes,
So I think this is a repetition of the earlier studies where they have shown the efficacy of close reduction. But again, I feel that especially in lateral condyles, you should do what works well in your hands. I don't think that there is a big difference between between open reduction and close reduction, because the incision also in open reduction is not much. So I think the ability to achieve reduction is paramount. Whether it is closed or open, it doesn't matter.
yes,
Is my personal opinion.
The other thing is now here Jacob 3 is there considering song 3, 4, and 5. So there is no clarification how many of them, because they have not compared. They might have used Jacob classification from the outset. The problem with close reduction in song 5 is it's a tremendous radiation exposure to your hand, because you are every time manipulating, pushing. So we do not know on longer run what happens to your, radiation to your hand. That's one. Secondly, many a times, I have done a few song 5 close reduction, and I have found more stiffness in those patients compared to when I do open reduction. I don't know why, because you try to put wires for many times from the skin inside, and you are doing more fibrosis of muscle. While when you do open reduction, you see the reduction in front of you. You hold it with clamp or your fork, and then there is not much of that wire jugglery. You pass your definite wire. So that is my experience. And many a times when you do arthrogram, uh, uh, even a nicest arthrogram, you have doubts that whether this articular surface has 2 millimeter breach is there or not. Mandar, that is my. Sometimes I'm not confident of assessing that. What is your experience?
See, to be frank, my total
Yeah.
contact fractures is very very low. I
Yeah.
almost never. So my counseling to the parents is going to be open reduction only.
Yeah.
It is very rarely that I say कि ये सिर्फ closed में आ जाएगा. It is almost never.
Yeah.
And most of the time, in almost 90 to 95% of the times, it is open reduction only. It is very rarely that I am satisfied or confident with my close reduction that I accept the close reduction and pin it.
Yeah. Ashish, what is your practice?
Yeah, Maulin, that's very pertinent comment about arthrogram. And I used to be a big fan of arthrograms, but I am moving away. I looked at some of my X-rays and I was questioning that whether is it changing anything, and in my opinion, it doesn't.
Yeah.
So there are newer papers out of San Francisco, I believe. Ishan Swarup has published that the arthrogram doesn't change anything. So
Mm.
this practice of doing arthrogram, when to do before doing putting the wire or after wire has also been questioned. I think
Mm.
it would be interesting to know the comparison between percutaneous screw versus open reduction, because
Mm.
Absolutely.
I think that that's emerging as a very valid option for treating these fractures.
Fine. That's a great paper. And again, this may not. What is most important is to achieve 100% anatomic reduction. And Dr. Kutub asked, "Do you see anteriorly?" Yes, we all see the anterior joint line. The metaphyseal reduction is important, but more important is intra-articular reduction. So there are a few techniques. You might use a headlamp to see inside, or you use a anal retractors, which are long Langenbacks, so that you can retract it well. And there are some tricks. We may talk in subsequent pediatric trauma module, and we have one session on techniques of lateral condyle fixation, so that you would like to attend. Let's move on to the next paper. See, all the delegates, you must mute your this thing. It is disturbing, and we should be mature to understand that now. You should mute yourself, okay, unless you are giving any comment.
Good morning, everyone. Sir, are you able to see the screen?
Yes, we can.
Yes. Good morning, everyone. So this was a paper which compared the outcome of clubfoot, idiopathic club feet, which were treated with either POP or synthetic cast. So it was a comparative study. This was published in Journal of Pediatric Orthopedics in 2021, and the authors were Federico et al. So it was a retrospective study and it was conducted at two different institutions. Coming to the background of the paper, the aims were it was to evaluate the clinical outcome of children with idiopathic club feet, which were managed by Ponseti using POP and semi-rigid fiberglass. The hypothesis of the study was in skilled hands, the type of the casting material does not influence the final outcome. Only if the principles of the Ponseti technique are applied appropriately. So this was the hypothesis on which the paper was studied. Coming to the materials and methods, all idiopathic club feet, all newborns with idiopathic club feet were managed by Ponseti. There were 85 consecutive children with 136 feet. Out of them, 42 were managed with POP at an Institute 1 and 43 with semi-rigid fiberglass at an Institute 2. And the severity of the disease was assessed by Pirani score. The inclusion criteria were confirmed idiopathic club feet, children younger than 21 days at the time of first cast, and they should have not received any previous treatment elsewhere. And the minimum follow-up that they have taken into account is 3 years. They have excluded positional club feet, non-idiopathic club feet, prior failed treatment, and the follow-up which was less than 3 years. So 136 feet were taken into account, and Group A had 68 feet which were treated with POP, and Group B had 68 feet which were treated with semi-rigid fiberglass. Tenotomy was done in 65 patients of the 68 feet in Group A, and only 63 underwent tenotomy in Group B, that is with semi-rigid fiberglass. After the completion of treatment, all the children were given Michel-Ponseti foot abduction orthosis, and clinical assessment was done with each cast change and 3 monthly interval for 1 year, followed by yearly interval later on. The statistical analysis of this was done using Stata software and the Fisher exact test for categorical variables and unpaid t-test for quantitative parameters. Coming to the results of the study, what is very significant in this table is that there was not much difference between the mean Pirani score at the start of the cast as well as mean Pirani score at the end of the cast in both of them. And they had equal amounts of relapses as well. And bilateral cases were more, and the percentage of males were more. So no difference between the mean number of casts. One important finding in this paper was the mean number of casts which were applied were lesser in the semi-rigid fiber group, and the total time in casts was obviously lesser because they had less number of casts. Patients in Group B, few number of patients, only 63 underwent TA tenotomy compared to 65 patients of Group A. And relapses were equal. 4 foot underwent relapse in the first, and the 4 in same thing. And the mean age at the time of relapse was more in Group B, that is semi-rigid group. So coming to the discussion part, by surgeons or orthopedic surgeons use POPs because of its good availability, lower cost, and more than everything, the moldability. It has better moldability. And the rationale behind using the SRF was it is easier to remove, it is lighter. Parents reported more comfort of the child with an SRF. Even though it was lighter, it was a more robust material. And POP had more risk of thermal burns, and SRF had less risk of thermal burns. And coming to the comparative studies which were done, one study done by Iden et al. Have reported greater parental satisfaction in children treated with SRF. And Pitna et al. Showed that lower Dimaglio score at the end of casting in POP group, not in SRF. But this present study did not note any significant differences in relapse rates. And the total number of casts and total time of cast was higher in patients treated with POP. And one study, Merco et al. Reported inherent stiffness of SRF and lower yield strength gave inferior results. Another important thing is considered was the time spent in cast removal. So the authors felt that when POP was used, it required special soaking area and dedicated staff to remove it. Whereas SRF was easier to remove, it could even be removed at home. This was one advantage they have found in this paper. But the overall outcome says that in experienced hands, there were comparable clinical outcome with both the cast materials. So to conclude, we can say that SRF is a valid alternative to POP, but its cost can be a cost-benefit analysis. It is difficult to use in this part of the developing world. But SRF can be used in high-income countries at referral centers where there is less staff and high outcome of patients where it is easier to remove the SRF material. limitations of the study. This was a retrospective study with limited number of patients, and there was some amount of statistical bias due to bilateral club feet. And the patients were treated according to each institute's preferred technique. So that was one important point. And what's needed is we need future prospective randomized trials and a larger study group to know which material has more benefit over the other.
So Ashish, your take on this paper, nicely read, Buddha. Thank you.
Yeah. Nice presentation. So three things I thought about it. Basically, yes, it's a good technique, but I mean the age group which they are talking, younger kids like 3 weeks old or so, does it really make the difference? In my opinion, in older children who are likely to break the cast, like 8 or 9 months older, definitely it's a very good option. Then who is putting on the cast? Because doing the manipulation or doing the molding of the cast can be difficult using the soft cast. So to the center A and center B, there might be people of varied experience, or that is something we need to take into mind. And again, yes, as discussed, the cost that remains an option. So, in my opinion, even though they are talking about younger kids, they have been studied in older children. What we see, um, yeah.
Yeah. So I agree with you, Ashish. And to me, when it comes to POP and a soft cast, the difference is only the ease of removal of plaster. I have interviewed a lot of families, and I asked what, as you know, that we have come up with a parents guide. So I interviewed a lot of families, and many of them had an issue that to remove the cast, and for removing they have to put the child's feet in a warm water. That's a problem. The children, some of children, they don't like it at all, and they cry. So they told me that you must find out something where the plaster removal is easier, and we don't need to soak it for a long time. Some of the plaster material can be unrolled if we just make them little wet, and but most of the families nowadays, they are okay with the way we do it. They bathe the child on the day they come to us, and they dip the legs fully in the warm water. Children enjoy their bath, and it's very easy for removing. The synthetic cast cost is one thing, but and removal might be, you can unwrap or just cut it. That's an advantage. But as I feel that molding is very important part of Ponseti technique, and it's a gradual molding which we, that advantage is not there when we use this synthetic cast. So we can, the molding is little less. Otherwise, the relapses are not dependent on what cast material you use. For pressure areas, again, it's pressure burns is again an experience thing. If an experienced surgeon would use the synthetic cast, that should not happen. The one thing I would like to narrate here is when I had to give an oration in Ahmedabad Orthopedic Society, I had emailed Jose Mokwendu and had said what has changed in Ponseti technique over last couple of decades, and he said the problem is people are changing the things, but the age-old method yields perfectly good result. So you stick to the old method and you will find great outcome, as Dr. Ponseti did. And I believe in him. He's right that we should continue with the plaster material. Yeah, thank you, Goda. And let's move on to the last paper of today. Mandar is probably scrubbed for his case. Yeah, Johannes. Any
Yes, sir.
comment if you have, you can put in chat box, and we'll be able to take them.
hope my screen is visible.
You can do the full screen. It is. You can go to the slideshow and start from beginning. That can help. No, on the slideshow after animation. Yeah.
Good morning, everybody. Today I'll be reading about fat graft versus fibrin glue for tarsal coalition. This paper was a study conducted by Swanger et al. In Miller School of Medicine in University of Miami, Florida. It was a retrospective comparative study, which is a level 3 evidence, and it was published in Journal of Pediatric Orthopedics in June this year. So the aim of the study was to evaluate the effectiveness of fibrin glue as an interposition material when compared with fat graft, and they compared the rates of coalition recurrence and wound complications. So it was a 22-year retrospective cohort study, and they included feet which underwent primary resections, and the interposition materials were either fat graft, which were either gluteal or local fat, or fibrin glue. And they excluded the feet which underwent secondary resections, or they had coalitions other than talocalcaneal or calcaneonavicular, and the resection surgeries which were done along with other deformity procedures. And all these patients were followed up by the primary surgeons, and the coalition recurrence was defined as a symptomatic reossification, which was confirmed radiologically and which required an intervention later. And wound complications were incision site issues, which required further prolonged antibiotics. And the children which had gluteal fat donor site issues were noted separately, other than the foot incision wound complications. So there were a total of 122 feets, equal number of males and females, and the mean age was 12 years. And the calcaneonavicular coalitions were 85, and the rest were talocalcaneal. And amongst them, fibrin glue was used in 29, and fat graft was used in 96, out of which 56 were gluteal. And this is how the fibrin glue compared with fat graft in terms of the complication outcomes. Coalition recurrence was in 2 in fibrin glue cohort as compared to 4 feet in the fat graft cohort, but it was not significant since fat graft had a higher number of feet, and the wound complications were 7 in the fat graft as compared to 1 in the fibrin glue. This also is not significant since the fat graft cohort had a higher number. And out of the 7, 3 were in the donor area in the gluteal fat. And the average follow-up was 14 months, ranging from 2 weeks to 7 years. Fibrin glue, it is composed of clotting proteins, mainly fibrinogen and factor 13, and it mimics the final common pathway of coagulation. And in vivo, it induces tissue adhesion. So in 2013, Weatherall and Andrew Price, they studied fibrin glue as an interposition graft for coalition resection, and they studied 9 children with 12 feet as a retrospective and study, and they got excellent outcomes in which all the children were able to return to sport, and they had no reossification or wound-related complications. And they have advocated that the fibrin glue, it works well within the resected coalition, and it forms a barrier which prevents recurrence, and it helps in scar healing also. And they've also suggested that the increased cost of fibrin glue will be offsetted by the increased operating time for graft harvest from gluteal side. There's another study which was done in 2017 where fat graft and bone wax was compared with the extensor digitorum brevis for calcaneonavicular coalition resection. And fat graft and bone wax had significantly lesser reossification at 4% and 6% as compared to extensor digitorum brevis at 40%. And they have concluded that autogenous fat graft and bone wax provided significantly more pain relief and functional score as compared to extensor digitorum brevis interposition. Since coming to limitations, since it was a retrospective cohort study and it was a single institution study, and also 10 different surgeons were involved in the study period of 22 years. And so the surgeons come with different surgical techniques and procedures. So these were the main limitations. Also, not all the feet had pre-op and post-operative range of motion documentation, and they have not used patient-related outcome measures and functional scores. And to assess the recurrence, post-operative imaging was not available on all the patients. Implications for our practice, fat graft, it has additional donor site morbidity and it may increase operating time. But fibrin glue has additional costs, so we have to decide between the two, and both have similar outcomes. Thank you.
So, Johan, that was very nicely read paper. And I'll invite Ashish to make his comment on what do you think about this paper.
Yeah, I think tarsal coalition is not that common. You do not see many tarsal coalitions. So I think yes, locally available fat graft could be less. So it's a very valid option to use.
Right. So I think Mandar is not there. Mandar, are you there? Okay. So about this paper, one thing which all the fellows should learn, that one group had 29 patients and other group has 93 patients. So there's a huge difference in the number where we are comparing, but the authors have done a good power study. So whenever you are comparing a smaller subset with a larger subset, you have to check that what are the outcome parameters and whether that parameters is okay with this number. So power of study you have to check, otherwise that paper will not be accepted for public, or that paper will not have any value. So they have done it well. So that point of view, it is okay. Now coming to the, all the limitations which Johannes has mentioned, there are more than 10 authors, so there are different methods. The fibrin glue we have been using for brachial plexus reconstruction, that cost 15,000 Indian national rupees, while bone wax cost around 700 rupees. So Ashish, what I have done over last few years, I use this extended digitorum brevis interposition, but before doing that, I use bone wax on both this calcaneum and the navicular surfaces,
Okay.
and then once I achieve absolute hemostasis, then I transpose EDB and fix it on the plantar site with just like an event transfer we do. So that has worked well, and that is cost effective, and it's kind of Indian jugaad we do. So maybe if we have substantial number of patients,
You should write.
we can study that. And I am not sure how to interpose EDB when you do talocalcaneal coalition. So in those, I have done only one. There I have used this fat interpose and bone wax combination. But more commoner is a calcaneo-navicular coalition,
Yes.
where you can use this bone wax and this thing. Again, the fibrin glue, the method of how to put fibrin glue in the resected area, I asked Joanne to read about it, because it's a liquid kind of thing which takes its form in about 1 or 2 minutes, and you have to make it in your operating room. So I would be interesting in reading that paper of how, because the area you resect sometimes it's quite a big area,
Yes.
and and the cut surface they keep on pouring
Yeah.
blood because they are cancellous surfaces. So how they did the hemostasis, and that is important. So we try to wipe the blood before we put fibrin glue when it comes to plexus reconstruction, so that technique of using that. So in a constraint, because again in India, these coalitions are not covered under Mediclaim. You have to write something else, otherwise it will not be insured. So we always try to use a lesser cost thing, and we recently heard interview of Dr. Benjamin Joseph that in Manipal they innovated many things to cut the cost of patients, because we have 80% of Indian patients, they are not well affording. So if it works, that EDB with bone wax or fat, then we can go ahead with it. There's another method one can use, but this study needs to be further robust. If it's showing clear cut advantages, then we will use it. If the results are same, then we might continue with what we have been practicing. So thank you very much, everyone. And those who are interested in receiving PDF of these papers, you can you can message in this fellows group, and our fellows will share those papers. I thank Ashish and Mandar for their valuable time. Mandar took long in fixing supracondylar. I don't know why. But thanks for your time, guys. Chinmay, Goda, Meet, and Johannes, you have read it well. Thank you very much. Have a good day. And from next week onward, we'll meet with pediatric trauma techniques. And Johannes will coordinate and head those sessions. So we'll have more interesting pediatric trauma coming up from next week. Yeah?
Thank you, sir. Thank you, sir.
Thank you very much.